Welcome to the session of critical care subspecialty, and we invite you on behalf of Reliance Institute of Critical Care Emergency Medicine, and we would be obviously 2024 would be a busy year, so we would continue with our endeavor on critical care subspecialties or super specialties, whatever way you look at it. So we already had been very regular on nephrology and neurology. This is our second session. We have started with oncology, and very soon we'll come up with the other specialties like hepato, endocrine, imaging, hematology, and infectious disease on that part. So today we have our second session on critical care neurology by Dr. Ishu Goel. Thank her to be kind enough and giving a time from her very, very busy schedule. And she is a wonderful person, brilliant neurologist, also a human being who is managing so many aspects of her life. She is trained in Delhi and now working in Mumbai, and she's one of the most learned person I've met. She is deputy consultant in our department of neurology, and to also support the entire process, we would also have very shortly Dr. Arun Shah sir, Professor Arun Shah sir will join, who is the Director of Neurology in HN Reliance Foundation, and also to give us viewpoints on the critical care aspects. Professor Dr. Rahul Pandit, who is also Director for the Critical Care Department, will also join pretty soon. If not, he has joined. So we have an eager audience, so I won't take any more time. So over to you, Dr. Ishu, and we would be discussing today the neuromuscular disorders in ICU angle. And feel free to ask questions. You can put it in the chat box. Appropriate time, we would interrupt Ishu and ask her certain questions for the sake of the discussion itself. Otherwise, we can also take the questions at the last. So over to you, Ishu. You can start.
Good evening, everybody. Thank you, sir, for such kind words. And thank you. I would thank Dr. Aruncha, sir, and Dr. Rahul Pandit, sir, to give me this opportunity, and you also, sir, to give me this opportunity to discuss one of the most important topics that we very frequently come across in ICU, and sometimes it leaves us baffled as to what is the reason of a person developing new onset weakness or worsening of the weakness, or why we are not able to wean off a person from the ventilator. So the answer sometimes lie in the neuromuscular disorders. So today I'm going to discuss about the neuromuscular disorders that we commonly and sometimes uncommonly come across in our ICUs. As sir said, please feel free to ask any of the questions wherever I'm not clear, and it would be good to have a healthy discussion. I'm not able to. So to begin with, we have a variety of neuromuscular disorders that we see in the ICU. These disorders may be pre-existing or may be previously undiagnosed, or they may be a complication of critical illnesses. When I say the disorders may be pre-existing, for to list a few, we have motor neuron diseases. We very well know the course of ALS, amyotrophic lateral sclerosis, which eventually in the course of the disease leads to bulbar weakness, and the patients do land up in our ICUs where they have to be ventilated, and unfortunately we are not able to take them off the ventilator. So such disorders are pre-existing, which worsen, and that is why they land up in the ICU. Other disorders which are pre-existing and may lead to may have an increased weakness or increased ventilatory requirement is myasthenia, which is very well managed in our ICUs and by the neurology team. Other disorders which are previously undiagnosed, like for example, is AIDP, acute inflammatory demyelinating polyneuropathy, like GBS, in which a person rapidly develops weakness and or respiratory weakness as well, and appropriate early treatment is paramount. And CINM, which is a complication of critical illnesses, critical illness myopathy, critical illness polyneuromyopathy. They are commonly seen where the hospital stay is prolonged because of some critical illness, super added by multi-organ dysfunction, which we are going to discuss subsequently. So this is a panorama of disorders which may be pre-existing, previously undiagnosed, or may be newly acquired within the ICUs. So, the neuromuscular disorders and the critical illnesses, they work both ways. Neuromuscular disorders may complicate critical illnesses by causing ventilatory failure and to they contribute to prolonging the ICU stay, hence increasing the morbidity. Like again, if we talk about myasthenia, if they land up with some superadded infection, some organ dysfunction, because of the underlying myasthenia, the control may falter because of the superadded infection or superadded critical disorder. So they ultimately may, the two hand in hand, may increase the hospital stay, the ICU stay, as well as the morbidity. Conversely, critical illnesses may cause neuromuscular disorder, again like critical illness myoneuropathy, thus complicating the pre-existing disease, and ultimately both lead to increased morbidity and increase in the ICU stay. Then, as I said earlier, it can be pre-existing or new onset or critical illness. If we have to classify the neuromuscular disorders that we commonly see in ICU, we can start from in the neuraxis. We are talking about the lower motor neuron disorders. So in the neuraxis, we start from the spinal cord. So pre-existing disorders like transverse myelitis may present to us with the increasing weakness, or if the lesion is higher up, then we may have respiratory dysfunction as well, or maybe because of some post-operative disorders. In the post-operative period, the spinal cord may suffer ischemia, or some underlying process, some underlying infection may lead to the formation of abscess, leading to spinal cord compression and again paraparesis. Then coming to the anterior horn cell, ALS and poliomyelitis are pre-existing, whereas the lesser common ones are maybe newly diagnosed, which is not very commonly seen here, like West Nile virus and poliomyelitis. Then in peripheral nerve disorders, we have pre-existing GBS, CIDP, and paraproteinemic neuropathies. Very recently, we had a gentleman with paraproteinemic neuropathy who had a very prolonged ICU stay, but ultimately we were able to wean him off the ventilator and send him home. Then new onset disorders of peripheral nerve may be discovered within the ICU, like porphyrias and toxic neuropathies. And the patient may acquire critical illness polyneuropathy because of some underlying critical illness. Then from the nerve, we go to the neuromuscular junction, myasthenia gravis and its presynaptic counterpart, which is the Lambert-Eaton myasthenic syndrome. They may be pre-existing and ultimately become worsen, involving the ventilation. And botulinum and tick paralysis also may be pre-existing, or they may be newly diagnosed in the ICU as well. Then sometimes it happens that myasthenia is not previously diagnosed, and it is the first encounter where the person is not being able to wean off the ventilator, and we call it unmasked myasthenia gravis. Then critical illness related, we have prolonged neuromuscular blockade, which we will be subsequently discussing in a post-operative period if adequate reversal of the anesthetic agent is not given, or because of some underlying electrolyte imbalances, the neuromuscular blockade may be prolonged, leading to ventilatory failure in a patient who has been prematurely deventilated. Then coming to the muscular disorders, periodic paralysis, a patient may already have a diagnosis of periodic paralysis, and then because it is episodic, so may come with an episode of paralysis, or within the ICU stay, we can have critical illness myopathy, or rhabdomyolysis may also develop. At this point of time, I take the opportunity to also talk about Igilon 5, although it is not a neuromuscular disorder, but since its presentation may mimic ALS, this also we recently saw in the ICU. It may mimic ALS with bulbar involvement, with fasciculations, muscle wasting, muscle weakness. So all these characteristics may mimic ALS. And the course of illness, although it is an autoimmune process, but still it may be subacute to chronic in duration. It is usually accompanied by sleep disorders and gait imbalances. So this is how, by taking a careful clinical history, we may suspect Igilon 5 disorder in a patient who has clinical symptoms similar to ALS. Why I am discussing Igilon 5 here is that an important feature of Igilon 5 disorder is the bulbar weakness, which again may make the patient prone to ventilator, dependent on ventilator, and we may not be able to wean him off the ventilator. So although it is not a neuromuscular disorder, but it may mimic one. And since it is an upcoming disorder which is not very commonly recognized, so I thought that I would mention it here, although I'm not going to discuss it in detail any further. If there are any questions or anybody wants to discuss IGLON 5 in detail, I'm most welcome to do that after the presentation. So the two main clinical features by which the patient present in the ICU with a neuromuscular disorder is one of the progressive weakness, the differential diagnosis of which we just now discussed. The other is failure to wean off the ventilator. And the differential diagnosis is again according to the Neuraxis. In motor neuron disorders, we have a myotopic lateral sclerosis, then poliomyelitis, GBS, critical illness, polyneuropathy, myopathy, heavy metal toxicity, vasculitis, etc. Then in neuromuscular disorders, we have myasthenia, Lambert-Eaton myasthenic syndrome, botulinum toxicity, organophosphorus toxicity. And then in muscular disorders, we have rhabdomyolysis, muscular dystrophies, and critical illness myopathy, which is very important entity which needs to be recognized and treated early. So these are the two clinical features with which these neuromuscular disorders may present to us. So beginning with the most important and the treatable one, the Guillain-Barré syndrome, AIDP. So we all know about GBS. It is not a new entity, and we are very well trained to diagnose it early and to treat it early. So just for the sake of discussion, AIDP is acute inflammatory demyelinating polyneuropathy. It is due to some autoantibodies, mainly the antiganglioside antibodies, which are generated in response to certain infections like Clostridium difficile, influenza virus, and recently detected COVID virus. We saw a huge number of cases of GBS post COVID also. And even now, we sometimes it is it is not possible to detect which kind of infection was that. But in a period of 4 to 6 weeks preceding the onset of weakness, we generally get a history of acute respiratory infection or a diarrheal infection, post which the weakness has started. So these are the common preceding features, and most commonly GBS presents with an ascending paralysis involving the lower limbs symmetrically, followed by upper limbs. If it is very, very rapidly progressing over a few days or a few hours is less likely, but yes, over a few days, if it is rapidly progressing, then we may suspect that it is going to involve the respiratory functions as well. Other common features associated with the GBS are respiratory involvement we already talked about. Then pain in the legs, which may be because of arachnoiditis or radiculitis. Then autonomic disturbances are also very common in a case of GBS. What is not common in GBS and should raise a red flag against the diagnosis of GBS is early and prominent bladder involvement. So if we are getting early and prominent bladder involvement early in the course of disorder, then we must question our diagnosis. So this is the common presentation of GBS. And although the characteristic, the prototype we already know, but there are many variants of GBS as well. And suspicion should be high to diagnose these variants because again, they are treatable conditions and we should not be missing them. So the GBS is mainly a demyelinating disorder, but certain varieties like AMAN, which is the axonal variant, and acute motor neuropathy, which is the axonal neuropathy, and then acute motor sensory axonal neuropathy, which is the AMSAN variant. Both of these are axonal. Rest of the GBS is predominantly demyelinating disorder. So there are various variants of GBS. The percentages are listed here. So the pure motor variant may be there's a huge range of frequency of these cases, 5 to 70%, where motor weakness is there without sensory signs. But even then on electrophysiology, if it is done in a adequate window period, in adequate duration of time, we may see some sensory involvement in the electrophysiology. Then paraparetic variant, which is 5 to 10%, in which only the lower limbs are involved. Then pharyngeal brachial cervical variant, in which there is a weakness of pharyngeal and cervical and bulbar muscles without any lower limb weakness. So such atypical presentations may leave us confused, and the index of suspicion should be high to classify them as GBS, because classically in these variants, we may not get the typical electrophysiology to support our diagnosis. Then bilateral facial palsy with paresthesias and the pure sensory variants. There are two other variants as well, which is the Miller-Fisher syndrome, which is 5 to 25% incidence, in which we have ophthalmoplegia, ataxia, and areflexia. But then again, we may not have all the three parameters to classify this disorder. They may occur separately also. Even ophthalmoplegia may be present, and whenever ophthalmoplegia is present, pupillary reflexes may also be impaired in a significant proportion of these patients. And then again, the electrophysiology may not be classical. Then comes the Bickerstaff brainstem encephalitis, which is the only GBS variant where consciousness can also be impaired, and it is accompanied by ataxia and pyramidal signs as well. So again, Bickerstaff brainstem encephalitis is the only variant of GBS where we may have reflexes on the hyper side. Classically, by dictum, the reflexes may be hypo or they may be absent. They should be absent. But generally, in majority of cases, we do not get hyperreflexia. But in Bickerstaff brainstem encephalitis, this rule may not follow, and we may get other pyramidal tract signs as well. So taking a careful history is important. So what is the diagnostic criteria of GBS? So we generally follow the NINDS criteria for diagnosing GBS. The features required for GBS diagnosis are progressive muscle weakness of more than one limb associated with areflexia or hyporeflexia. The features that support GBS are progression of weakness for over 2 to 4 weeks. So it is a subacute, acute to subacute disorder, but mostly it is acute and the patients present to us within a few days. The involvement should be symmetric. The signs and symptoms are generally, the sensory symptoms are generally milder, but usually people do have tingling numbness sensation. But if it is a predominant sensory involvement with the classical joint position impairment, then again we should reconsider our diagnosis, or we should find some other causes of demyelinating polyneuropathy like paraproteinemic neuropathies. Then cranial nerve involvement is common, facial nerve involvement is very common, which is also bilateral facial nerve involvement in many cases. Recovery begins after an initial nadir of 2 to 4 weeks. Autonomic dysfunction is common, and CSF proteins are generally high. And then the features which cast the diagnosis, doubt on our diagnosis, are the persistent or prominent bladder bowel function, marked asymmetry, high CSF cell count, polymorphonuclear leukocytosis in the CSF, and central nervous system signs, except we can get them in Miller-Fisher variant and the Bickerstaff brainstem encephalitis variant. And then strongly against the diagnosis of GBS is obviously the establishment of some other criteria, other diagnoses like porphyria, diphtheritic infection, and botulinum, etc. So for the sake of diagnosis, for in GBS, history is the most important. History and clinical examination is the most important one. It is supported by the electrophysiological test. So, but the drawback of electrophysiological test is it takes some time for the electrophysiology to be positive, approximately a week. But early in the course of disease, like by the second or the third day, we start getting some changes in the electrophysiology, like impersistence of F wave. So these are the earliest signs which we get. And then gradually, when the disease progresses, after a few days, we can document prolonged distal latencies and slowing of conduction velocities, which are typical of demyelinating disorders. But within first or second day of presentation of the onset of symptoms, generally electrophysiology may be normal, but it does not exclude our diagnosis. The other important test is the CSF examination. Sorry. The other important test is the CSF examination, where we may get high CSF protein. But again, if it is done within the first week, within initial 5 days of the onset of the symptoms, the protein may not be high. The protein generally is higher second week onwards. Then again, we should be very careful in interpreting our investigation that we are carrying out. Then the third investigation is the blood test that we generally do are the anti-ganglioside antibodies. The positivity of the anti-ganglioside antibodies depend upon which variant we are talking about. The antibodies differ from case to case. So there is generally an anti-ganglioside antibody panel available, which we usually send. Then for the diagnosis of GBS, we should also be considering the differential diagnosis, which may mimic GBS, most important one being hypokalemic periodic paralysis. So serum electrolyte should always be checked before we establish a diagnosis of GBS, and serum potassium levels should be checked. Then other differential diagnosis like spinal cord disorders can be easily ruled out by careful neurological examination. But if it is predominantly involving the lower limbs only, then Corda-Equina syndrome and all must be considered. And the other rarer causes should be kept in mind, like botulism and tick bite paralysis, etc., which are not very common. But again, the treatment is entirely different and they are treatable. So the list of differential diagnosis of GBS should be kept in mind. Then when to admit the patient to ICU is an important question. So indications to admit in the ICU are very clear cut when the progression of the disease is very rapid. Whenever they within a day or two, if the person has become bedbound, then most likely he is going to get a respiratory involvement as well. Then evolving respiratory distress with imminent respiratory insufficiency, which can be documented by use of accessory muscles, dyspnea, and severe autonomic dysfunction along with bulbar weakness. These are all the important indications that the patient should be admitted in ICU and should be observed very closely and treated immediately. Then what are the parameters for the imminent respiratory insufficiency? They are the clinical signs of respiratory distress, like again the use of accessory muscles, breathlessness at rest and while talking, increase in heart rate and respiratory rate. Then single breath count, in which we tell the patient to take a deep breath and then count slowly. If the single breath count is less than 15, usually the normal breath count is over 20. But if it is less than 15, then we can say that the patient has imminent respiratory failure. Then, if the vital capacity is less than 15 to 20 ml per kg or is less than 1 liter and abnormal ABG with hypoxemia, then all these are the parameters of markers of imminent respiratory insufficiency. There is a score which is called the IRAMS GBS respiratory insufficiency score, where at the time of the first encounter, when the patients present to us, we can estimate or we can give a fair enough idea. We can have a fair enough idea then that what kind of which patients are going to land up with respiratory insufficiency. So this score is based on the days between the onset of weakness and the hospital admission. If it is rapidly progressive, less than 3 days, then the score is higher. Then involvement of facial and bulbar weakness at the time of hospital admission, and then MRC scoring at the hospital admission, where we check for shoulder abductors, flexion of the arm, then wrist extension, then hip flexion, knee extension, and dorsiflexion. So these six muscles we check and score them according to the MRC grading. And then the higher the score, the lower the IRAMS GBS respiratory score. So after adding all these parameters, we get the IGRIS score. And the higher the IGRIS score, there is a higher risk of respiratory failure within 7 days of the first examination. So we all at the first encounter, we can very well make out that which patient is having a risk of respiratory insufficiency. But if it is objective, then we can document it properly and then the patient can be put under observation also properly. So, not all the patients of GBS require treatment with IVIG. So, what is the criteria of treatment of GBS? When the patient is unable to walk 10 meters independently, or when the GBS is rapidly progressing, even if he is able to walk uh, with support, or even if he is able to walk, but still the weakness is rapidly progressing, still the patient is in a kind candidate for the treatment. There are two treatment modalities which we very well know. One is IVIG and other is plasma exchange. So IVIG is given at a dose of 0.4 gram per kg for 5 days, and it should ideally be started as soon as the patient presents to us if he is a candidate and within 2 weeks of symptom onset. Plasmapheresis, the ideal dose is 200 to 250 ml of per kg divided in 5 sessions, which are generally done alternate days so that tolerability increases, and it should be given within 4 weeks of the symptom onset. So there are various benefits and disadvantages of using both IVIG and plasma exchange. IVIG is generally contraindicated when the patient has thrombotic tendencies or when the patient has acute kidney injury. Whereas wherever there is hemodynamic instability or autonomic instability, which is very common in GBS, plasma exchange would be a little risky. And in cases of septicemia also, again, plasmapheresis should be done with caution. The advantage of doing plasmapheresis is it is more rapidly acting than IVIG, but ultimately there is no difference between the ultimate outcomes after using IVIG in Plex, and both are equally effective. So after treating, we have to monitor the progression. So, monitoring the progression has two parts. One is the respiratory assessment, and one is the motor power assessment. So, respiratory assessment, again, to objectify our evaluation and to properly document whether the person is improving or deteriorating. We can maintain a chart according to the following parameters: whether the person is using accessory muscles, what is the single breath count, and then a good rule to follow to assess for the respiratory status is the 20-30-40 rule. 20 is the there is a 20 is the vital capacity. Patient is at a risk of increasing respiratory failure if the vital capacity is less than 20 ml per kg, maximum inspiratory pressure of less than 30 centimeters of water, and maximum expiratory pressure of less than 40 centimeters of water. So if these three parameters are present, then the patient is at an increased risk of respiratory failure. This was about the respiratory assessment. Coming to the motor power assessment, we already always have our MRC grading system. And after all the assessment, we can also mark a GBS disability scale to prognosticate the patient, whether the patient is able to walk 10 meters or not, whether he is able to walk aided or unaided, whether he is bedridden, or whether he requires ventilation. So this score helps us to prognosticate the patient. Then care should also be taken about the swallowing, coughing, and autonomic system evaluation. So autonomic system evaluation also plays a very major part in a case of GBS, because sometimes autonomic fluctuation may lead to hypertension, and we have had cases where because of the hypertension patient has also suffered intracranial hemorrhage. So autonomic fluctuation may be massive, leading to bradycardia, leading to tachycardia, leading to gastroparesis, and again, hypertension. And similarly, swallowing and coughing should be carefully monitored to prevent secondary complications like aspiration pneumonitis. Then, apart from these other complications that should be monitored carefully are the cardiac arrhythmia, hospital-acquired infections. To improve the quality of life, pain should be adequately managed. Delirium depression should be managed adequately. Urinary retention should be taken into account, although it is not very common to have urinary retention in a patient with GBS, but since they may be bed bound, so ultimately they might have to be catheterized and UTI should be prevented. Because of facial involvement, corneal ulceration may be present, that has to be dealt with. Then dietary replenishment should be done because already the patient is in a catabolic phase. And electrolyte imbalances, compression neuropathies, all these are the common complications which may add to the morbidity of the patient. So once we have done with once we are done with IVIG, sometimes like in 40% of cases they do not respond to initial treatment. So what next? What are the guidelines for a repeat treatment or for an alternative therapy? So contrary to the traditional practice that we generally do, and it is sometimes found to be effective also, the role of an alternative therapy or a second therapy has not been adequately documented. There are not enough guidelines to support the role of repeat IVIG or change over to plasmapheresis or vice versa. So this is an article published in 2019 where they say that at 1 month the disability scores were there was improvement in the disability score, but ultimate outcome was the same. And in other guidelines all over the world as well, all the guidelines have unanimously said that a role of alternative therapy has not been very well established, but sometimes it does help, and then the decision should be based on the clinical parameters of the patient. So, and after the non-failure, after the patient improves, in 6 to 10% of cases, we do document treatment-related fluctuations, which is defined as a clinical deterioration within 2 months after an initial treatment-induced clinical improvement has been documented. If a patient improves clinically and then within 2 months he deteriorates again, then we call it as treatment-related fluctuations. Treatment-related fluctuation may happen because of the ongoing autoimmune process, but the effectiveness of the IVIG or the initial treatment may have worn off, but the autoimmune process is still ongoing. So in such circumstances, an additional dose of IVIG is warranted and it generally helps. Then it should be differentiated from acute onset CIDP, which is again seen in 5% of cases. Acute onset CIDP is defined as 3 or more treatment-related fluctuations or clinical deterioration after 8 weeks of the disease onset. So it is important to differentiate between treatment-related fluctuations and acute onset CIDP because the management for the both change. it is primarily IVIG in treatment-related fluctuations, whereas we may consider giving steroids in acute onset CIDP. When I talk about steroids, I would like to mention that in GBS, as we all know, the role of steroids are not at all recommended, and they may be harmful. So the mainstay of the therapy is IVIG or plasmapheresis. Then, for prognosticating the patient, we have already talked about one score. 80% of them regain ability to walk independently at 6 months after the onset of the disease. But long-term complications like neuropathic pain, fatigue, and mild neuropathy may persist over a longer period of time. Their electrophysiology may not recover to the baseline. They may have mild ataxia left or mild weakness left, but they continue to improve, and majority of patients improve within 6 months of the disease onset. So, the likelihood of inability to walk independently at 6 months can be calculated by using the modified Eramus GBS outcome score, where the age of onset, preceding diarrhea, and MRC score at 7 day of hospitalization as is taken into account. So, the higher the score, the more is the likelihood of the patient not being able to walk at 6 months of the disease onset. So this was about AIDP. And if there are any questions regarding this, I would be happy to take. Otherwise, we'll go on to the second disorder, which is the critical illness myopathy and neuropathy. So I'll begin with the critical illness polyneuropathy, myopathy, or a combination of both, which is the most common one, critical illness polyneuromyopathy. It is the most common cause of neuromuscular weakness in the ICU, and it is a common cause of failure to wean off the ventilator as well. Isolated critical illness polyneuropathy is rare, and whereas a combination of polyneuropathy and myopathy is most common, which is 83%. So the diagnosis of this disorder is commonly delayed because of concurrent encephalopathy. The patient is already in sedation and possible underlying pre-existing paralysis. And once the sensorium of the patient improves and the sedation is weaned off, and still the patient is not being able to take off the ventilator, or the patient is not moving, then we suspect critical illness polyneuromyopathy. Until then, it has mostly it has already been established by the time we initially start thinking about the critical illness, these kind of critical illness disorders. So the differentiation between the critical illness myopathy, polyneuropathy, it is easier said than done, because usually it is a combination of factors. As of typical myopathy, the weakness is more proximal than distal in critical illness myopathy, whereas it is more distal in critical illness polyneuropathy, and it is mixed with proximal predominance in polyneuromyopathy. In critical illness myopathy, sensory preservation is seen, but there is atrophy, and there is variable atrophy with distal sensory loss in critical illness polyneuromyopathy. So the pattern of these disorders conform with the pattern of the generally seen myopathies and neuropathies, which is distal predominance in polyneuropathy and proximal in myopathy, with or without sensory involvement. So, what are the risk factors for these diseases? We all know that traditionally it was talked that steroid use is puts the patient at risk of critical illness, polyneuromyopathy. But in the initial case reports and the initial studies, it was seen that the use of steroid was the studies of these critical illness polyneuromyopathy were limited to those patients who were already on steroids. So the causative association was not well found. But then in the subsequent studies, it was studied that it was seen that the use of steroid causing critical illness polyneuropathy is not very well established. Rather, we have other disorders like status epilepticus, asthmaticus with mechanical ventilation, systemic inflammatory response syndrome, multi-organ dysfunction. All these disorders which prolong the ventilatory requirement, which prolong the ICU stay, they contribute to formation of critical illness polyneuromyopathy and prolonged mechanical ventilation as well. One factor which is definitely increasing the risk of critical illness polyneuromyopathy is hyperglycemia, and we should also always keep a check on the blood sugar levels to decrease the risk of getting this problem. So the increased risk with renal replacement therapy or neuromuscular blockade or the use of steroids is not very well established. Coming to the diagnostic criteria of critical illness polyneuromyopathy is the patient should be critically ill. But in myopathy, even if the patient is not very critically ill, but still has been exposed to neuromuscular blocking agent, corticosteroids, and multi-organ in the setting of sepsis and multi-organ failure, then they are at a higher risk of developing critical illness myopathy. Limb weakness is present in both. Difficulty in weaning of ventilator is present in both. Then in critical polyneuropathy, we have axonal type of sensory motor neuropathy in our electrophysiological studies. Whereas in critical illness myopathy, we have preserved sensory responses but reduced CMAPs. Then the muscle excitability is hampered in critical illness myopathy. Other causes should always be excluded whenever we talk about critical illness myopathy or neuropathy. And the diagnosis is finally rested upon by the muscle biopsy, where we see myosin loss and muscle fiber degeneration. Other causes of neuropathy in ICU, like heavy metal toxicity, vasculitis, and porphyria, should always be ruled out. So, in the diagnosis of critical illness, polyneuropathy or myopathy, first is the clinical history and the examination. Then, looking at the presenting risk factors, the present risk factors in the case scenarios. Then we go to the electrophysiology. Electrophysiology is always doubtful. Like they do contribute, but because of the ICU setting where there are a lot of artifacts present, so their interpretation has to be done carefully because the extremities may be cold, there are ventilators attached, there are numerous infusion drips attached. So all these things may lead to faulty electrophysiological study. So they should not be entirely relied upon. Then because of the concomitant drugs like the statins and all, they also predispose to having myopathy. And then for the myopathy, CPK levels can also be checked. They are elevated in case of critical illness myopathy, but would be normal in critical illness polyneuropathy. And even in critical illness myopathy, they are not very high, but yes, they are definitely on a higher side. So this is about the diagnosis of critical illness polyneuropathy and myopathy. Then coming to the treatment, so the role of IVIG has not been established in such situations, but intensive control of sugar and other risk factors does help. Then functional electrical stimulation, again the efficacy is yet to be established, and basic the basic underlying mechanism of using a functional electrical stimulation is repetitive stimulation of the nerves and the muscles, leading to constant flow of electrical stimulation. But then again, the efficacy is yet to be established. Early mobilization and exercises are the best, and the early rehab should be targeted whenever the patient is stable enough, and nutrition should be taken into account. The supplementation by omega-3 fatty acids has been shown to increase the anabolism. Basically, critical illness polyneuropathy, they happen because of increase in the catabolism and the difference in the excitability of the muscle and the nerve. So omega-3 fatty acids, they act as antioxidants. They help in, they act as an anti-inflammatory as well. And then they are anabolic and help in the replenishment of the nerves and the muscles. So, but the role of IVIG is not very well established. And it is important to differentiate whether it is a critical illness polyneuropathy or it is GBS, because then again the role of IVIG is well established in case of GBS. The prognosis wise, critical illness myopathy is better than critical illness polyneuropathy, but over 80% of critical illness polyneuropathy patients have evidence of polyneuropathy even after 1 year of discharge. Their recovery may continue up to 24 months. So this was about critical illness polyneuropathy and myopathy. Coming down to myasthenia gravis. So I'm not going to discuss about the general myasthenia gravis that we see in the OPDs and is managed on an OPD basis, but the basic pathology of myasthenia gravis is from the presynaptic membrane via the voltage-gated calcium channels, the quanta of acetylcholine neurotransmitter are taken to the presynaptic membrane. They are released in the synaptic cleft, and they are taken by the postsynaptic membrane. The receptors on the postsynaptic membrane are present, acetylcholine receptors, which uptake this neurotransmitter, and ultimately the electrical current is transmitted after the acetylcholine binds to the acetylcholine receptors. So the antibodies to any of these receptors lead to failure of the transmission of action potential in the postsynaptic membrane, leading to the muscle paralysis. The various receptors that commonly contribute to myasthenia gravis are acetylcholine receptor, antibodies against this, or anti-musk antibodies, which are these are the two most common, and anti-LRP4 is also fairly common, where we have seronegativity to both anti-musk and anti-acetylcholine receptor antibodies. These are basically the membrane-bound receptors to which antibodies are seen. But in certain circumstances, we also have antibodies to intracellular proteins like myosin, titin, cortactin, actin, and rhinodine receptors. And whenever antibodies to such proteins are seen, we should be looking for some underlying malignancy as well. So, in ICU, we commonly come across myasthenic crisis, and we generally deal with myasthenic crisis in the ICUs. So, I'm going to restrict my talk just to myasthenic crisis, which is a complication of myasthenia gravis characterized by worsening of muscle weakness, resulting in respiratory failure that requires intubation and mechanical ventilation. Approximately like 15 to 20% of myasthenia gravis patients are affected by myasthenic crisis once in their lives, and most commonly a patient with myasthenia gravis would land up in myasthenic crisis within 8 to 12 months of the diagnosis, because this is a time when the patient is being managed, where the appropriate dose of corticosteroids and other immunosuppressants are being established. And if it is not properly titrated, and if the dose of the steroids is not properly given to the patient, that is the time when the disease is most unstable and the patient may land up in myasthenic crisis. But it may also be an initial presentation in one-fifth of patients, where the diagnosis may become tricky and may get delayed because of lack of background history. And women are twice as likely to be affected as men. The common precipitating factors for myasthenic crisis we know are the infectious states, then stressful situations like pregnancy and emotional stress, environmental stressors, surgery. All these may contribute to the precipitation of myasthenic crisis. Then use of certain drugs like antibiotics like aminoglycosides, gentamicin, streptomycin, macrolide antibiotic, all these beta adrenergic antagonist, calcium channel antagonist, and magnesium. These all may lead to may contribute to the precipitation of myasthenic crisis. So whenever we are dealing with a patient of myasthenic crisis, the list of the medication that have to be avoided should be very clear in our minds. Then, how to assess the respiratory function in myasthenic crisis? The same that that the assessment that we used in a patient of GPS, the same assessment holds true here also. We look for the use of accessory muscles. We look for the presence of dyspnea and single breath count. Again, if the single breath count is less than 20, the patient may be having respiratory dysfunction. Similarly, in vital capacity, less than 1 liter per inspiratory pressure of less than 20 centimeters of water, and expiratory force of less than 40 centimeters of water, the same 20, approximately the same 20, 30, 40 rule may indicate towards involvement of respiratory dysfunction. But regardless of all these indices, which we don't commonly measure, the need for mechanical ventilation in itself defines myasthenic crisis, and we should be quick in dealing with such patients. So how to manage a patient of a myasthenic crisis? Again, we divide the management into two parts. One is the respiratory management and one is the neurological management, where we give the immunomodulatory therapy. So because it is an urgency to treat myasthenic crisis, first of all, we talk about the respiratory management, where we intubate and mechanically ventilate. In elective intubation is always preferred, because we shouldn't be waiting for a person to crash and develop aspiration pneumonitis. So elective intubation is always preferred. Then the tidal volume should be kept at 8 to 10 ml per kg, and pressure support should be kept at 8 to 15 centimeters of water. Weaning should be considered when there is a significant improvement in the strength of the neck muscles and the adjunct muscles, because by then we expect that the neuromuscular transmission has already started happening, and now the ventilatory maintenance would also be adequate. It is indicated by a vital capacity of more than 15 ml per kg. So we should be looking carefully at all the parameters, and we should be predicting the risk of prolonged intubation more than 14 days, which is commonly seen in the age of more than 50 years, when the peak vital capacity in itself is restricted because of maybe some underlying respiratory problems. If it is less than 25 ml per kg, then we should be expecting a prolonged intubation. If serum bicarb is more than 30 millimoles per liter, and if it is associated with thymoma, because again thymoma has if a thymoma is present, then we expect that continuously antibodies against the acetylcholine receptors or the acetylcholine receptors are continuously being generated. Then, if the patient has been successfully shifted to BiPAP, or the patient is being maintained on BiPAP, then we should look at serum bicarb, and serum bicarb should be kept below 30 millimoles per liter. Apache 2 score, which is a constellation of various parameters like hemoglobin, TLC count, serum electrolytes, renal function test, the basic GCS score, and the MRC score of the patient. By all these parameters, we can calculate the Apache 2 score. And if it is less than 6, then we can predict that the patient can be successfully maintained on BiPAP. But the sole indicator of BiPAP failure is a rise in PCO2, which, if more than 45 of mercury, indicates that BiPAP is not adequately helping the patient, and then ventilation should be considered. Then in the neurological management, the same that we used in GBS patients, IVIG and plasma exchange should be considered with the similar indications and contraindications. In the myasthenia crisis, corticosteroid should be started along with IVIG and plasma exchange, so that by the time IVIG and plasma exchange are over, by that time the level of corticosteroids is well maintained and the patient can be successfully maintained without any further deteriorations. Acetylcholine esterase inhibitors are usually discontinued because excessive use of acetylcholine esterase inhibitors may lead to cholinergic crisis, which again may increase the bulbar dysfunction and the paralysis. They may worsen that. And apart from that, they may also lead to increased secretions, diarrhea, fasciculations, all the complications which may complicate the patient's mechanical ventilation and may also hinder in the weaning off from the ventilator. The electrolytes should be well maintained, because then again hypermagnesemia and all may precipitate, may again deteriorate the patient's condition. Hematocrit should be maintained over 30% for adequate oxygen supply, and adequate nutrition should also be taken care of. So this was about the common neuromuscular disorders that we generally deal with and come across. Just I'm taking the opportunity to discuss the less common causes like periodic paralysis. I would be quick in these so that we have adequate time for discussion. So the most common one is the hypokalemic periodic paralysis, which is an important differential when we are dealing with a patient of GBS. We usually encounter a patient of hypokalemic periodic paralysis in early childhood only, mainly in the second decade, where the person has episodic muscle weakness, and it is generally because of calcium channel mutations, the CAGNA1S mutations, and less commonly in the sodium channel mutations. It is because of the leaky potassium channels, which lead to the failure of neuromuscular transmission. And it is usually seen in adolescents when in the morning they consume a high carbohydrate meal, which leads to increase in insulin secretion and further leading to hypokalemia, precipitating an episode, and then exertion followed by rest. Generally, it leads to generalized weakness, generally spares the facial and respiratory muscles. It generally lasts only for hours, and it is associated with hypokalemia. The sodium channel associated hypokalemic periodic paralysis differs from the calcium channel mediated hypokalemic periodic paralysis by the fact that sodium channel associated hypokalemic periodic paralysis is generally seen in adults, and the episodes of muscle weakness are shorter lasting. The episodes of muscle weakness caused by calcium channel mutation last for more number of hours, generally 6 to 7 hours. But the sodium channel mutations ones, they last for a lesser number of hours. But the management differs in the two, because the calcium channel associated hypokalemic periodic paralysis responds to acetazolamide, whereas the sodium channel associated hypokalemic periodic paralysis may worsen with acetazolamide. So this is the pathophysiology, where there is a leaky current which causes premature depolarization. So by the time the action potential reaches the membrane, it does not conduct, because the membrane is already in depolarization, leading to failure of action potential and hence the weakness. The treatment, the diagnosis is generally based by the features of hypokalemia in the ECG, which is the prolonged PR interval, and the U waves, prominent U waves. And it is supported by electromyography, where we can get a low Cmaps. So here we can differentiate between GBS, where it is predominantly demyelinating, but hypokalemic, we will not get demyelination, but just an axonal drop. and then by muscle biopsies and all, but it is generally not required because a simple documentation of and correction by supplementation of potassium is enough for the diagnosis. So the treatment rests on avoiding the high carbohydrate diet and giving acetazolamide. A new drug is under trial, pumitamide, which is a sodium chloride co-transporter inhibitor, but its role has not yet been completely established. Whenever we are using acetazolamide in a dose of 125 mg once a day, we should be warning the patients regarding its side effects of renal calculi and paresthesias in the hands and feet. Then coming to an anesthetic condition, prolonged neuromuscular blockade. So whenever a patient is taken for any kind of surgery, neuromuscular blockade, some kind of anesthesia is given. And before the patient is taken back or shifted back to the ICU or to the ward, it is very well established that there is no residual paralysis in the patient. So the absence of residual paralysis means that neuromuscular transmission has recovered sufficiently. The patient can move normally, he can breathe normally, he can cough out his secretions so that there is no aspiration of gastric contents, and he can maintain his airway. Residual paralysis after the emergence of anesthesia is associated with prolonged muscle weakness, oxygen desaturation, pulmonary collapse because the pulmonary musculature is also not maintained, and acute respiratory failure. All these can lead to a severe permanent brain damage and death because the patient may get extubated while he still cannot maintain his airway, leading to hypoxia, leading to brain damage. So whenever we are dealing with such kind of an episode where unexplained has happened, we must look into the fact that whether there was a residual paralysis. This residual paralysis may be because of two conditions. First is that we have not ensured that the patient is actually out of the anesthesia or not. And certain conditions like hypophosphatemia, hypocalcemia, hypermagnesemia, and these electrolyte imbalances, along with underlying infection, use of aminoglycoside antibiotics, they all may precipitate a patient. Additionally, there may already be an underlying neuromuscular disorder which was undiagnosed, and since we did not know about it, any kind of neuromuscular blockade may have added upon it, leading to the residual paralysis. So we can ensure that there is no residual paralysis by doing train of four test in which we repetitively stimulate a muscle. The principle is same as that of RNST, where a decremental response indicates that the patient is not yet completely out of the paralytic agent. And modern techniques like acceleromyograph, which records the extent of contraction of the muscle. When this ratio of the first stimulation and the fourth stimulation is equal, that means the muscle is adequately contracting to the repetitive stimuli and the neuromuscular junction is functioning adequately. So if we are not very careful about the post-anesthetic respiratory depression, we may land up our patient in brain damage, pulmonary complications, and upper airway obstructions, hypoxemia, as well as risk of reintubation. Then the last two slides in which I'll be talking about the tick paralysis, very uncommon. It is a non-infectious disorder, but it's important to recognize because the management is simple as the removal of the tick. So it is an important differential diagnosis of GBS, where neurologic syndrome is characterized by acute ataxia and progressive ascending paralysis, the same as GBS. It is caused by the salivary neurotoxin of the engorged tick of the most commonly the species is the dermacenter species, but there are a multiple number of ticks that may cause a similar condition. It primarily affects the motor pathways by blocking the sodium channels, and it is important to differentiate it from GPS. We may keep treating the patient as GPS by giving IVIGs and all. The patient still may not respond because the culprit agent is still there, and mortality is high as 12% if the patient is left untreated and the tick is not removed. And finally, the botulism. It is caused by toxins formed by anaerobic gram-positive Clostridium botulinum. The bacteria may be foodborne, wound-borne, inhalational, or iatrogenic, and it causes receptor-mediated endocytosis and cleavage of proteins. Again, we go to the same neuromuscular transmission that we studied in myasthenia. We were talking about postsynaptic membrane over there, and this one is the presynaptic endocytosis, which leads to the failure of acetylcholine release in the synaptic cleft. Being a large molecule, it does not cause the blood-brain barrier, and hence the CNS involvement is not there. The patient is conscious alert, but he may have multiple cranial palsies leading to ptosis, pupillary involvement, followed by descending flaccid paralysis, proximal as well as distal involvement, and respiratory paralysis and death. The diagnosis, again, it requires a high index of suspicion, careful history taking of the food intake, careful history taking of any kind of wound which may be secondarily infected, and then demonstration of botulinum toxin in the serum or stool or in the gastric fluid or the food that the patient had consumed. This was the neurotoxin, and demonstration of the Clostridium organism per se in stool or wound culture. The treatment is supportive care and administration of botulinum antitoxin, which is a combination of a variety of antitoxins. So these were the main conditions which are which are known to cause the neuromuscular diseases. There are many more conditions, but because of the constraint of the time, I restricted my talk to these conditions. So to summarize, there are many neurological conditions which commonly present themselves in the ICU with weakness and respiratory distress. Diagnosis should be based upon looking at the patient in total, his background, his comorbidities, his signs and symptoms, and the circumstances of his presentation. High index of suspicion is required because of poor general condition in the ICUs with critical illness. The patient may be encephalopathic or sedated. Electrophysiology helps in the diagnosis, but the diagnosis is mainly based on the clinical history and examination. And along with the particular management for the particular disease, early rehabilitation also helps for a full, complete functional recovery. Many thanks for listening to me for an hour almost. And I would request for any of the questions that anyone has. I would stop the slide sharing. And I would also
Yeah, please
request
do.
Aruncha sir and Rahul Pandit sir to give their valuable comments on the
Sir
same.
has joined. Issue.
I can't see, sir.
I can see, sir. Also, I think he's in the. Okay, so maybe I would ask you certain questions to
Please,
start
sir.
with, so that
Yes.
you started with GBS. So I written it that there were so many variants of GBS,
Yes.
and and along with the Miller Fisher or the Vicker stuff and all others. So why, apart from obviously for examination purpose and others, that is different, but clinically or in practice, why knowing so many variants of GBS is important? Is it is to clinch the diagnosis, or there are differences in the prognosis, or is there any difference in the treatment approach?
So it is basically all three that you mentioned. So first of all, it is important to recognize it because first of all, the prognosis matters. The prognosis of the acute. Sir did not have the link. आपने भेजा नहीं था सर को?
मैं अभी भेजता हूँ. आई थॉट यू शेयर्ड. अभी भेज रहा हूँ. आप भेज रहे हो इशू?
सर आप भेज दो, मैं भी भेज रही हूँ.
अच्छा, सॉरी, ये फॉपा हो गया, सॉरी. आई हैव सेंट. हाँ, प्लीज.
Sir, so first of all, it is important to recognize the variants because again the treatment varies only in the Miller-Fisher and the Bickerstaff variant because they are not very well responsive to IVIG. Still, if even if we recognize Miller-Fisher and the Bickerstaff variant, we still treat them in the same manner. Although we know that they are not very well responsive to the typical management of IVIG. The second is the prognosis. The prognosis of the Aman and Amsan variant is not very great as compared to the traditional AIDP variant. Especially whenever it is preceded by Clostridium difficile diarrhea, the prognosis automatically goes down. So wherever axonal predominance is seen in a case of GBS, then the prognosis is affected. So, and again, for the sake of diagnosis, the we should be having knowledge about the various variants of the GBS. But yes, and specifically what type of antibodies to send. So there are the antibodies linked to different GBS variants are separate. So to establish the diagnosis, we must identify the clinical variant that is there. But obviously, for the treatment and prognostication also, it is important.
And regarding, you very clearly mentioned that the EPS or the CSF study could be normal in the initial phases or so.
Yes, sir.
So should we, very just like pancreatitis, acute pancreatitis, when we very specifically do our CT scan after 5 days, should we time our EP study and CSF? And if a patient is presenting early, should we only rely on clinical history and
Sometimes
examination?
it does happen that, like I said, that the classical and for the complete picture of electrophysiology to get established, it takes time. But we do have early markers like impersistence of F waves and a slight delay in the latencies, which may be seen early also. So if we are able to find even these changes in the NCV, it may add on to our diagnosis. Secondly, it may also contribute to give us a suspicion on some alternative diagnosis, like in that patient that we had in our ICU, Mr. Amit. In his case, even on third day, the latencies were unexpectedly dramatically prolonged. The conduction velocities were very slow, which was totally unexpected in a case of GBS. So right from the beginning, we knew that we are not dealing with a simple case of GBS, and there has to be something additional to it. So right from the first go, we had sent the serum protein electrophoresis, and we were trying to find some additional cause. So in that also, apart from the clinical examination, which showed predominantly sensory involvement, and to an extent that joint position was totally impaired, the electrophysiology also added on to give us a hint that it is not a simple case of AIDP, and that's why
So,
maybe.
so for the ICU guys, I would rather say that you go ahead when you have a suspicion or a clinical diagnosis, do the electrophysiology and CSF. This,
Exactly.
if it doesn't get you a diagnosis of GB, right, GBS, it
Then we
may
don't
rule
rule it
out
out.
certain other rare possibilities, and you can pretty well, if it is a normal or near normal, you can after 5 7 days you can repeat it, right, to clinch a
Yes.
diagnosis.
Yes, but then diagnosis is always clinical only, sir. It just adds on to our knowledge. It just adds on to our diagnosis, and then if in future we need to see how much the patient has recovered, for that we
Right.
can get a baseline NCV to compare it with the future NCV, so that we know how much is the patient electrophysiologically improving.
IVIG or Plex.
So it depends upon the clinical scenario only. It depends upon the patient clinical condition. Both are equally effective. The cost
So
factors
it,
matter.
none of them has a superiority over the other,
No,
right?
no. Both of them
Okay.
are equally effective. Just the duration
Yeah.
of action is shorter
Is
in
there
one.
any logic? Is there any logic to combine both?
No, there is no evidence to combine both of them, and there has not been any additional benefit. This has been adequately studied in a multiple number of trials, the combined use, the separate use. So the separate use
Or a
was as
sequential
established.
use?
Sequential use is also not established. So, as I clearly mentioned, that sequential use in the case of treatment failure is not recommended as per the trials. But in our clinics, all of us generally tend to use it, and it sometimes helps also. But the combined use has been shown to be detrimental rather than being effective.
So, what should be your clear message clinically? That can it be in refractory situations as a rescue method? Can there be a sequential use? And in that case, what should be the ideal sequence? Does it matter if one comes before the other?
It does not matter which is coming first and which is going later. Because the IVIG, if we are giving IVIG, then we generally wait for its effect to come for at least a week, and then we do the plasmapheresis. So that latent period is there in which we do not know the patient is improving or not improving. So that is one factor. But there are clearly no particular guidelines that whether we should be using plasmapheresis first or IVIG first. Either can be used first depending upon the patient's clinical condition. If the patient is in impending respiratory failure and but hemodynamically stable, so we may go ahead with plasmapheresis also. But traditionally, we generally start with IVIG and then go to plasmapheresis.
Anyone wants to ask a question? I am doing all the questions to her. She would be so angry with me.
No, not at all.
Anyone? Rohan, Kesri, Pradeep, Avni?
Yes, sir. Sir,
Rohan, you
Rohan
want
here.
to ask a question? Yeah,
Yes, yes, sir. Yes.
please.
So, my question was: is there any specific guideline on the time duration that we should use if in cases of treatment failure, like after 2 months, should we reconsider again IVIG or plasmapheresis, or there is no guideline on the time duration as well?
There is no particular guideline on the time duration as such when we should consider it as a failure, but we typically don't wait for 2 months before we because the patient is clinically, if the patient is not clinically stable, then we wait for at least, like, we just wait for the effect of IVIG to come for 5 to 7 days. If there is not even a flicker of improvement in the patient's condition, although it is not established anywhere regarding the role of the next therapy, but we do go ahead and give the alternative therapy, but because ultimately we have to keep the patient's status in mind. So but there is no clinical guideline as to till what time we have to wait and till after what time we have to consider. According to the trials, it says that there is no role of second therapy to be given, but then we have a patient at hand who we have to treat, so we generally go ahead and give it after waiting for
Sure.
approximately 5 to 7 days of IVIG.
Okay. Thank you.
Anyone else? Anyone from our
Hello,
neurology department? Yeah.
sir,
Okay,
Vikas.
Vikas. Yeah.
Yeah. So, madam, what's the? I mean, when you should going to think about the rituximab? I mean, we have one patient in 1324, Mr. Modi, for which we have used initially IVIG, then Plaques, and then we use the rituximab for that patient. I
Yes.
mean, so what sort of criteria? I mean, you will see for the further therapies.
See, for if we are just talking about a clear-cut case of AIDP without any super added immune mechanism, like in Mr. Amit Modi, we had paraproteinemia as well. He was IgM kappa positive. He was MAG positive. So it was not just the traditional AIDP. He was a paraproteinemic neuropathy who had presented with GPS. So that's what right from the beginning, his clinical examination was not fitting it with typical AIDP because he had predominant sensory symptoms. His joint position was impaired right from the day one, which we generally don't commonly see in a case of AIDP. Then secondly, his NCV was grossly abnormal, which again we do not see on the third day of presentation. So we knew that this is not a clear-cut case of AIDP. Then his all the paraprotein, serum protein electrophoresis was positive. So the idea of giving rituximab in him was not to treat the AIDP, but to treat the paraproteinemic
Paraprotein.
neuropathy that he was having. So there is no role of rituximab or any other immunomodulatory treatment except IVIG and plasmapheresis in a case of AIDP. So, but in a case of AIDP, if he is not responding, if the patient is not responding after a single dose, and the patient is critical ventilator dependent, we go for plasmapheresis. But over months, if the patient is not adequately improving, his power is not improving, or if the electrophysiology is continuously going down, then we can't call it as AIDP, but it may be a acute onset CIDP because the
Yeah.
patient never improved and ultimately he is developing a neuropathy which had presented acutely. So we may be dealing with acute onset CIDP. In that case, we can give according to the guidelines, we can give a monthly, 4 weekly, or 6 weekly doses of IVIG, which the dose being 1 gram per kg and not 2 gram per kg, which we give in AIDP. So that is one treatment modality for CIDP. And then we can always try, if we have established that this is CIDP, by doing maybe a nerve biopsy, or if there is a sural sparing which is consistently there over months, and we have established that this is CIDP, then we can treat the patient as a case of CIDP, and then there are multiple immunomodulatory therapies available. So it all
So
depends
immunomodulators doesn't have a clear-cut role in a,
in AIDP, they don't
specific
have.
AIDP. No
No,
role.
no.
So unless it is some sort of secondary or sort of primary process causing a secondary AIDP like picture, so there is no role because I think that's pretty clear and obvious
Yes,
also.
sir. Yes, yes. Thank you, sir. Thank you.
Anyone else? सबसे कम केसरी पूछता है अवनी any question from your end, our friends from internal medicine? Okay, so I think
Sir,
this one, yes, please.
sir, Rohan here. Sir, sorry, one
Bolna.
more question.
Please ask
Uh,
as many as you can. Don't worry.
yes.
Madam is
Yes, please, please.
on our disposal and she would love to answer those.
Absolutely.
Ma'am, in hypokalemic periodic paralysis, as you mentioned that acetazolamide inhibitors, acetazolamide cannot be used because it may worsen in the
That
sodium.
is only in hypokalemic periodic paralysis. That is because of sodium channel mutations. The most common ones are calcium channel mutations
Calcium.
only. So we don't generally send a genetic testing to check whether it is sodium channel or calcium channel because of the clinical presentation. If it is presenting in the adolescent age group only, if we have a history of periodic paralysis dating back to his adolescent age groups, then we go ahead and give acetazolamide. We generally do not go for genetic testing because the most common varieties are the calcium channel ones and in which acetazolamide works well.
Okay, got it. Thank you.
And regarding this one, that your CIP or CIM, right? Critical illness, polyneuropathy or CIA, but there are a lot of overlap. Is there any difference in the prognosis? You said that uh, myopathy may have a
Myopathy,
better prognosis.
yes, sir. So if it is only critical illness polyneuropathy, like I said, like more than 80% of people may still be having some kind of neuropathy at the end of 1 year. Whereas in critical, if it is just critical illness myopathy, with the rehab and with the adequate nutritional replenishment and all, they improve significantly without leaving them with any disability. But generally, it is an overlap, and if myopathy is more or neuropathy is more, that is really difficult to tell.
Any specific treatment right at this moment, like you said, some sort of anabolic
So
anabolic
only
compounds
the
and
role of
others.
omega-3 fatty acids has been established. Rest
Hmm.
the nutritional supplementation only.
Is it
Adequate calories and proteins.
Lot of time that we have tried growth.
Dr. Pandit
Good
here?
evening, sir.
Dr. Pandit, yes, sir.
Is omega-3 fatty acid really helpful?
Sir, according to the
Hi. Is omega-3 fatty acid really helpful, beta?
sir, according to the studies, I read quite a few of them, and in every study, it has been mentioned that they help because they are anabolic and they are anti-inflammatory. So they do help.
In fact, Dr. Pandit sir, if you remember that a lot of things were similarly tried, growth hormone, anabolic steroids, right,
Correct.
in
Yes.
sort of way. There have been, but not very sure about the your
They may add on, but it is not a like the whole soul treatment. The whole soul treatment is just the rehab and the physiotherapy and all those things. It just has an ups. It may add on to the recovery of the patient. That we can put it that way.
right, and also that she has very nicely described the risk factors or the precipitating factors like sepsis,
Yes.
steroids,
Yes. Yes.
hyperglycemia, and others. Those are very clearly being mentioned by her.
Yeah.
Lastly, in your myasthenic crisis, right? We, as a critical care people, without internal medicine background, people who are from other subjects, right? We are very perplexed on the different antibodies those are, and also you enumerated so many antibodies. So, what should we look for, or what should we send? The standard ACRA or the entire panel of antibodies, or it should be sequential?
So generally, we prefer to send it sequentially because it does amount for the from the patient's pocket as well. Because the classical presentation, if it is just the ptosis, if he has a background of ptosis and the muscle weakness, the history is in the favor of acetylcholine receptor antibodies. And if the weakness is predominantly bulbar, involving the facial muscle, then it is a typical presentation for anti-musk antibodies. So if we have such a presentation where the muscle weakness, the proximal weakness is not more, but the patient has clearly presented with sudden onset bulbar weakness, then it makes sense to send both acetylcholine receptor antibodies as well as musk because it is a typical presentation for musk antibodies. But if there is no predominant bulbar weakness but sequential progressive proximal weakness, then we send sequentially first for the acetylcholine receptor antibodies. If it is negative, then anti-musk. And these days anti-LRP4 is also available. So in double seronegative, we sometimes send for anti-LRP4 also. But the clinical presentation for anti-LRP4 is again like anti-acetylcholine receptor antibodies only.
Last question that today you have seen this patient actually, 1307,
Yes,
where
sir.
you are also considering an acute myositis, which could be due to drug induced.
Yes.
Right? Any a little bit of on acute myositis, which can present as a neuromuscular disorder. Yeah.
So there are various causes of acute presentation of acute myositis. First of all, infective processes, they always present acutely with a massive rise of CPK, as we have seen. Then all the inflammatory myositis as well also have this high CPK. So nowadays, this terminology of polymyositis in inclusion body myositis, they have been outdated, and we are talk about just an overlap syndrome, which is precipitated by various factors. So these kind of neuropathies, and then again the medication-induced myopathies, like usually the statin-induced myopathy is not this acute, but then because so many factors are also contributing to it, so yes, maybe a drug-induced myopathy may also be one of the factor which we may keep in the differential diagnosis. But if we talk about sudden onset severe inflammatory myopathy, then we high on the cards we keep autoimmune inflammatory myositis or infective myositis.
So normally drug induced would be little indolent, not that
Yes,
this
yes.
much of acuteness
Yeah.
would.
But then if we
But you
have a
said
lot
that
of
there could be multiple factors playing and it can present something like that.
yes, sir, yes, sir.
Okay. Okay. So thank you everyone for joining, but most of the thanks and most of the hard work
Thank you.
done by Dr. Ishu. So thank you once again sincerely from all of us.